Thank you very much for the kind introduction, Dr. Kane. And at the outset, I would like to express my sincere appreciation and thanks to Dr. Sunil Thanvi for organizing this wonderful meeting. I think I've been really educated in the last 1 hour or so of listening to the various talks. And I think all of us are practically on the same page in terms of COVID and the vascular thrombosis. And this is something that during the COVID period, we also did see a lot of patients who came to us with COVID-related limb ischemia. So as you all know, there are a lot of papers which are now coming out into the environment on the coagulopathy, endothelopathy, and the vasculitis of COVID-19. And what SARS-CoV-2 infection does is it activates the macrophages, the endothelial dysfunction also happens, which leads to tissue factor expression, activation of factor 10 to 10A, and the coagulation cascade which gets activated, leading to this arterial thrombosis. So I think in all the vascular beds or the cardiac beds, everywhere it's the same problem. So a lot of papers have come out, and we are also in the process of publishing a paper on this one. So what are the treatment therapies? Because a lot of these patients come to us with acute limb ischemia or acute and chronic kind of a limb ischemia. What are the treatment options? And as you can understand, a lot of patients, and I will go through some of the cases that we've done where these patients were on ventilator, they have destroyed lungs. So we don't want to subject them to major procedures and all. So that's why you need to try to make the procedure as minimally invasive as possible. So treatment options when we look at in these patients with acute limb ischemia, powered suction thrombectomy, that is basically a catheter directed, and then using catheter directed thrombolysis in certain subset of patients. And in some patients, of course, you have a hybrid or open thrombectomy. And some of these patients did come to us with unmasking of the previous lesions. So that's why then you had to subject them to balloon or stent angioplasty. And of course, the last subset of patients who could just be managed medically, either they were in very bad shape by the time they came, or the ischemia which was there was not very severe. So when you look at this, the first case that we saw, that was almost, I think, in the month of September, a 53 years old male diabetic, history of severe COVID pneumonia. 1 month ago, he was on ventilator, now was discharged in stable condition and developed sudden onset severe pain in the left lower limb with cyanosis of the left forefoot and 7 days. And by the time he came, he had gangrene of the left first toe and the fourth toe, and dorsum of the foot, which was showing pre-gangrenous changes, decreased sensations in the foot, and the popliteal and ATA, PTA distal pulses were all absent. And a CT angio showed a thrombotic occlusion of the proximal popliteal artery out there with the extending into the TP trunk with reformation of pit, PTA, and mid peroneal artery. He had some disease even on the right side also, but since he did not have any tissue loss, so we were not really going to chase that aggressively. So what we did in this particular patient, as I mentioned, that since he was on ventilator with bad lungs, we didn't want him to be subjected to any open surgery. We did a right CFA percutaneous axis and left popliteal ATA and PTA thromboaspiration using a penumbra, which is a Cat6 catheter, which is there. And this is just to show you the procedure. Here you have an occluded popliteal artery. And then we are going up and down with this penumbra Cat6 catheter, aspirating the thrombus from trying to go across into each and every and branch all the three vessels of the tibials out there, going into the peroneal, the PTA, as well as the anterior tibial. And then after that, sucking out as much of the thrombus that we could. And then, of course, as you can see out here, you got a good result out here. The three vessel runoff, all the three vessels are running off very well. And post-operatively, the patient had Doppler flows of almost 60 centimeter per second in the ATA. The PTA was 40 centimeters. And subsequently, we had to do a debrima of the wound. We had to remove the gangrenous stores and then treat this patient with the dermal regeneration template, which is Integra out here, and then subject him to skin grafting. And this patient was walking around. And as the previous last talk, something, the clot thickens. So here, what we found in some of these patients is that the clot is always very, very thick and rubbery kind of a clot which comes out. So many a times it is not really very, very suitable clot for just doing thrombolysis. So this is something that we learned over the years, and we managed almost about 50 odd patients of COVID-related arterial thrombosis. And the clot is always very, very thick and rubbery. So one is not very sure if this will really melt with just plain thrombolysis. Another patient, a 62 years old man, a known case of diabetes, hypertension with severe COVID pneumonia 3 months ago, elective ventilation for 10 days, developed progressive gangrene of right foot since 15 days. And as you can see out here, the forefoot is looking, all those gangrenous patches are there on the first and the second toe, as well as the distal pulses are not palpable. The foot is cool to touch. And CT angiogram showed a proximal peroneal artery acute and chronic occlusion, reforming distally via the collaterals, and distal ATA and PTA were occluded. So the only vessel which was running off was the peroneal artery. So you had to do something to salvage that one. So right peroneal artery ATA and PTA balloon angioplasty was done via the left CFA endovascular approach. And as you can see out here, you can see the vessel, the peroneal is occluded proximally. ATA and PTA are, just tapering off. We took a 2.5 mm balloon. Then after that, with that, we kept on doing an angioplasty, and now we recanalized the peroneal artery. Then we said we might as well try opening up the ATA also. So we went right across into the dorsalis pedis using a 2 mm balloon, but you could see that there is a thrombotic lining. And same thing into the PTA also. We went across into all the three vessels and trying to, open up. But again, like I said, that there's a lot of thrombotic lining, and these were the patients where there's a lot of recoil because of the thrombotic lining. So we didn't really chase it, but since the patient had a beautiful peroneal runoff, which was going across and feeding the ATA and PTA territory in this case, we left it at that because the only other option that this patient otherwise would have been to do a proper embolectomy or something of the sort. But post-operatively, the duplex scan shows 100 centimeter per second flows in the peroneal artery with the foot warming up. And then after that, you can see that in these patients, the wound is nicely granulating out here. There's nice red granulation. Within 10 days, the wound was ready for skin grafting. The third case, a 65 years old male diabetic, was COVID positive, now recovered since 1 month. Again, presented with sudden pain in right lower limb and a bluish discoloration of the foot since 4 days. And this is the kind of foot which he came with. So as I said, we're just going to show a lot of these dirty pictures. So cyanosis of all toes with mottling over the dorsum, sensations were absent over the foot. The femoral was present, popliteal and distal pulses were absent. So this was a bit of a challenging case because there's an acute thrombotic occlusion of the popliteal artery in the P2 segment and extending into the tibial vessels. So here we decided that we will do a transfemoral fluoroscopic guided thrombectomy of SFA and popliteal artery and the BTK vessels. And this is what we did. We exposed the right groin, went across, and started doing embolectomy. As you can see, this embolectomy catheter going up all the way and removed a lot of clots from there. Then went across into the anterior tibial artery and removed clots. But what we found was finally there's a poor outflow. You could see that the popliteal artery, everything has got cleared off, but outflow vessels are not really that great. So the patient tended to reocclude in the BTK segment, and therefore we decided that since this is not really working, we decided to go and expose the popliteal artery below the knee. Did a thrombectomy from there, ATA, PTA, again, because our catheter was just reaching just above the ankle all the time. And here we were able to go across, a lot of thrombus lining out here. And finally, when we finished out here, you can see the ATA, it's running across, the DP is there, peroneal is there. So we had a good two vessel runoff out here, although the PTA collapsed, but ATA and the peroneal was running very well. And patient had a palpable DPA, there were good flows in the peroneal. The forefoot was amputated, whatever you saw, the wound was granulating well, back applied, and the patient was subjected to skin grafting. So I think the major purpose in any kind of acute limb ischemia is that we want to avoid a major amputation. Unfortunately, by the time many of these patients come to you, they already have these kind of pictures which are there. There's gangrene which is already set in. So our target is to improve the runoff in such a way that at least the foot can be preserved and the patient walks on his own legs rather than using a prosthesis. Another 58 years old female, obese patient, hypertension, diabetic, recent COVID recovery with cyanosis and bleb formation. All pulses were palpable except the PTA. And it showed an acute thrombotic occlusion of PTA. The rest were within normal. Since she had a normal anterior tibial and the peroneal, This was one patient. The challenges, there were a lot of challenges. 2D echo showed an LVEF of 35%. She was on BiPAP and oxygen dependence with an acute kidney injury. And the patient's relatives were unwilling to consent for any angiography and surgery. So therefore, we decided to keep this patient on uh, uh, best medical management, pushing the patient onto low molecular weight heparin. And this is, of course, the wound debrided after demarcation of gangrene after about 15 days, and then subsequently VAC application. As you can see now, this foot after 20 days is all set for skin grafting. So this is the final outcome. The SSG done after the end of 1 month. The wound is nicely closed, and this patient is now walking on her own. So to conclude, arterial thrombotic complications in COVID patients, we are seeing a lot of these patients, a prothrombotic state triggered by the global endothelial injury, and of course the pro-inflammatory milieu, which contributes to the cytokine storm. A non-atherosclerotic vessels in the relatively young patients and distal vessels involved. A higher rate of critical ischemia, major amputations were observed in various studies which have been published now. And I think what we need to do is assess each and every patient and decide what is the best course of treatment, the endovascular, whether it is hybrid, whether it is conservative management. So you really have to tailor the situation as per the case rather than trying to use a brahmastra of either doing only endovascular or surgery for every patient. Thank you very much for the opportunity. I bring warm greetings from my team at Sir Gangaram Hospital. So all this is possible because of having a wonderful set of colleagues out here who really are the ones who are the force which helps us in doing some good cases. Thank you very much.